So everyone, thank you for joining and welcome back to our first academic half day of the have with us Dr. Ryan, who is one of our neurology attendings on Mount. As you can see, she'll be discussing altered mental status. Again, Dr. Ryan, thank you so much for being with us today.
Yeah, it's my pleasure. Thanks for having me, and Happy New Year to everyone. Okay, yeah, so we're going to be talking about altered mental status, which is a pretty vast topic, especially for a neurologist, because a lot of what we deal with is altered mental status in various different forms. But I'm going to try to break it down a little bit for you all. We'll talk about just what it is and the different kind of components of altered mental status. We'll talk about sort of a general approach. And throughout this, we're going to be doing cases. So I hope that people will unmute. Certainly you can chat, or please feel free to unmute and just call things out. Normally in an ideal world, we would have like a whiteboard and I would be writing and it would be more interactive, but we'll do our best on Zoom. I also realized I had made some polls in my Zoom, but I can't actually share them because it's not my Zoom, so it's fine. We have it in here and we'll just do our best, but certainly your participation is very welcome. And we have cases kind of sprinkled throughout. So we'll talk about an approach to altered mental status. We'll talk about delirium. We'll talk about prevention and management. Okay, so just what is altered mental status? And again, it's a pretty broad topic, but it's, broadly a change in cognitive function or level of consciousness. And we'll talk about each of those in more depth. But it's an important thing to know about. Certainly we as neurologists hear about it a lot and see a lot of patients with, quote unquote altered mental status, but a lot of patients never come to us because you guys are managing them beautifully yourselves. So we'll kind of talk about sort of those earlier stages and where the approach that I would recommend. So 5 to 10% of emergency department patients have altered mental status, and the numbers are higher among elderly patients. More than 50% of these are admitted, so certainly a lot of them are in our hospitals. And the mortality rates can be very high. Obviously, it depends on the etiology, but can be as high as 10%, depending on where you're looking. So consciousness, so we're talking about altered mental status. So the way Plum and Posner, who were two kind of luminaries within neurology, Dr. Plum passed away actually from primary progressive aphasia in about 2010, but Dr. Posner is still a neuro-oncologist in New York City, and they wrote this book, Diagnosis of Stupor and Coma, and in that they basically broke altered mental status into the arousal and the content of cognition. So arousal is the level of alertness, the content is sort of the higher level cortical processing that allows us to be aware of ourselves and then aware of the environment and interact with the environment. So you can be altered on either of those fronts. So if we look at arousal very broadly, arousal and kind of alertness come from 3 places in the brain. So first, in the brainstem, you have the reticular activating system here. So if you're going to have someone who is altered or unconscious, you're going to either have to take out the reticular activating system in some way. You're going to have to bilateral thalami or get the cortex, bilateral cortices. So what I'm thinking of when I'm looking at a patient who is in coma, for example, I think about these 3 areas. I mean, the bilateral cortices can be a lot of different things. Metabolic abnormalities can hit sort of both cortices in that way. But if you're thinking about more focal lesions, you have to break it down in this way. Otherwise, most stroke patients really, unless it's a basilar artery stroke, are wide awake, right? So that's why I think it's very helpful to think about these 3 components. So this is, when we're thinking about arousal, this is what you might see in a neurology note: alert, appropriately interactive, normal affect, open eye spontaneously, regard. So these are the kind of components of the exam that are arousal. And there's, of course, a spectrum of arousal. So we were talking about coma, so that's complete unresponsiveness, no eye opening. You can have drowsy patients, you can have normal patients, and then you can have hypervigilance where patients are really awake and easily distracted. And, just in thinking about arousal and how you might measure it, I'm sure everyone has heard of the Glasgow Coma Scale, developed in Glasgow, Scotland in 1974. This is actually an image from the original paper where they described the scale and showed how you can actually track it over time. And this is actually a patient who had some kind of structural brain lesion. And initially on the scale, they were doing okay. And then they sort of started to drop off, and they actually had an operation and got better. And so this was where the authors were showing that the scale can really be useful in clinical practice. And I'm sure, again, we've all seen it used frequently. So I wanted to talk about this a little because I think it's got some practical implications for you all. So again, you may all know this, but I'll just touch on it briefly. The scale goes from 3 to 15. 3 is the lowest it can be. There's no 0. You get a point just for being alive on each front. 15 is the best, so higher is better. There's 4 different kinds of eye opening, 5 verbal responses, and 6 motor responses, and we'll go into them a little bit more. And when you're reporting it, the intention of the scale was really to report each of these out individually. So eye opening 2, verbal response 1, motor response 5, like that, as opposed to the global scale. Although I think in practice we see, that 1 number quite often. Technically, that should really be more for research. I try to report both, and I think that's probably best practice. So, so just to go into this a little bit more, the responses, and this is, by the way, flipped. So here we have the lowest is no response for each of these. And then this is getting better back to normal on the top. So a normal eye opening is just a patient has their eyes open spontaneously. If they open eyes to voice, that would get a 3. And if they only open their eyes to pain, that's a 2. From I'll go to verbal response. Normal person talking, oriented, able to say anything, that's a 5. If they're able to talk, but they're confused, so if you ask them the year and they give you the wrong year, that would be a 4. Whereas if they're talking, but it makes no sense, so this might be where you hear word salad or some kind of aphasia, that would be a 3. And then if they're just sort of mumbling or moaning, that would be a 2. And then the motor response is where it's a little tricky. And interestingly, in the original GCS, the original paper, there were only 5 levels here. But in sort of a subsequent modification they added a 6. So, I mean, normal motor is, you're able to move on command. Localizing to pain is where, if you kind of squeeze in the right upper extremity here, for example, the patient actually goes and grabs with the other hand, or if you, are helping them open their eyes, and they swat you away. So if they actually localize to the pain. And then withdrawal is if they take that hand that you're squeezing and try to pull it away from themselves, but in a normal way. In other words, like an actual flexion, which I think is a little bit confusing. It's really a withdrawal. And then this is what a lot of people ask me about on rounds is, what's the decorticate, what's discerebrate? I think personally, these are incredibly confusing terms, and I don't use them regularly, but in terms of the GCS, decorticate is the flexion response. So that's where the arms are flexed at the elbows and the wrists and sort of internally rotated, and the legs are extended. And then decerebrate is the extension, is where the arms are extended and kind of to the side, with the wrists actually flexed and the legs extended again. And so just briefly, decorticate again that's the level, that's a 3. And then decerebrate is a 2. So remember, as we get lower, we're kind of worse. Decerebrate was actually in the 19th century. Sherrington did these studies on live animals and actually anesthetized the monkeys and transected their brainstem, and that's where the decerebrate posturing was first described. Actually won a Nobel Prize for that. But the decorticate posturing is less well described, but roughly decorticate is kind of higher up. So D cerebratus in the brainstem, and D corticate is probably sort of a little higher up in the midbrain, red nucleus, whereas D cerebratus is a little bit lower. But this is, again, what those postures look like. And so GCS, there's a lot of data about correlating it with mortality. We're not going to go into that a lot today, but just one example in terms of head injury. Again, this is not, there's a lot of different things that you can, calculate a GCS for. A lot of people can be altered in many different ways, but if a patient has a head injury specifically, the more severe the head injury, the higher the likely mortality. And there are actually some graphs where literally it goes up with each score, or sorry, the mortality goes up as the score goes down on the GCS. So they're highly correlated in certain scenarios, but really the etiology makes a big difference, of course, and we'll talk about that more. So let's see if we can be a little interactive here. This is, I have 3 scenarios, and I'm hoping that people can unmute or type into the chat what you think the GCS is, and not just the total score, but what you think the EV and M are. So 49-year-old, no known medical history, found down. On exam, he grimaces and moans to noxious stimuli, but doesn't open his eyes. And when the examiner attempts to open his eyes for him, he slaps the examiner's hand away. Any thoughts on what the eye opening is? Oh, I see someone in the chat. Okay, fine, great. So he doesn't open his eyes, right? So E is 1. The V, he is sort of moaning, so that's a 2. And yeah, exactly. And for the motor, he's localizing, right? So that's a 5. Awesome. Okay, so oops. So these are they're pretty straightforward, but in practice, it can sometimes be tricky. I have to say the next one, I actually initially, I think I scored it wrong myself. So 66-year-old female, history of alcohol use disorder, found wandering. On exam, she was awake, speaking fluently without meaning and not following commands. So when she was asked the date, she said train. She localized to noxious stimuli, but didn't follow any of the commands. So what about this one? It's easier, but I wanted to use this as a jumping off point to quickly talk about something else. Yep, so great, thank you guys. So her eyes are open spontaneously, perfect, so that's a 4. She is speaking fluently without meaning. So this is where I think it's kind of tricky. So she's actually, what do we have here? Verbal is a 3. I think that one is a little tricky on this one. And then she's localizing but unable to follow command. So this is what I'm saying. It's actually, I think, tricky. She's confused, but she's actually not, it's not even, what's the date? And she says, 2000. It's what's the date? And she says something completely nonsensical, like a word salad. So that would probably be more like a 3, although there's probably some room for debate here. And I think I just wanted to put this one in here because does anyone want to say what they think she might have? Alcohol use disorder, speaking kind of fluently but without meaning. Does that ring any bells? Yeah. So exactly. So this is a Wernicke's syndrome, maybe Korsakoff. So probably a thiamine deficiency. And this is just in terms of thinking of like the range of altered mental status, over time, this patient could become, drowsier and less alert. But obviously, if treated with that high dose thiamine, might be able to improve. And the other thing she might have Does anyone know what the triad, what else she might have? So she's confused. She's kind of got this Wernicke's, she's sort of confabulating and not making any sense.
Ataxicate.
Yep. And the last thing is ophthalmoplegia, which someone asked. Yeah. So recently saw a patient like this who had actually been in the hospital for some time, being sort of fed, but not really enough, and sort of developed this where she was incredibly confused. Some, saying things, but it not making any sense, and actually had full ophthalmoplegia, couldn't move her eyes in any direction and couldn't sit on the side of the bed because she was had truncal ataxia. And with high dose thiamine, she actually completely improved. So really important to diagnose. Great. Okay, so the next one is a 28-year-old who presented after a motor vehicle accident, not opening his eyes, not grimacing or moaning to noxious stimuli, and extends in response to noxious stimuli in the upper extremities. It's more straightforward, but. Okay, so he is, oh, interesting. Maybe so I thought he was, there's a little room for, yeah, okay. So verbal, I thought he wasn't making any noises. So that, I don't think I described that well. So that was a 1, a 1, and a 2. Okay, great. So that's the GCS, and that's when we're thinking about arousal and that kind of first portion of consciousness. And then the second portion is where like neurology is, it becomes neurology in a lot of ways. It's the higher level cortical processing. It's the content of thought. And this is where it gets complicated. In fact, this content area is really like the cognitive exam. So just, this is like what you might see again on a neurology note, the patient, the orientation, the attention, their language, memory, calculations, praxis, abstractions, all of that. So obviously any one or multiple of these can be abnormal. And again, just the different ways that we test these, mini mental, MoCA, and then if you're really getting into it, and 4-hour neuropsych testing. And these are the ways that we can really kind of dig into what that content, what might be abnormal in content, and that can give us clues as to what's going on. So, like in our patients with, with an Alzheimer's dementia, then they might have a memory issue. Our delirious patients might have an attentional issue. Patients with aphasia from a stroke would have a language issue, and so on. So a general approach, again, noting that this is a pretty broad topic. So the first thing, and this is, it depends obviously where you are. If you're on the floor, presumably this has been taken care of, but people can become, of course, acutely altered, and we have to be thinking about these. I want to make sure that the airway, breathing, and circulation are stable, right? If someone comes in choking on a piece of steak, they'll be altered. And, that is the first thing that you want to think about is their airway. If someone has respiratory failure from COVID, right, they can be altered, and so on. So really important to make sure that the patient is stable enough to be doing this sort of deeper dive into the other aspects of their exam. And then you obviously want to look at vital signs. Can give you lots of hints for lots of things in medicine and neurology, as you well know. Blood glucose, a patient who took too much insulin or is hypoglycemic for another reason, that's a very high risk of mortality, but can certainly be very treatable as well. And in this case, always administer thiamine if you have any suspicion of malnutrition or alcohol use, high dose thiamine before that glucose. And then the other thing is always considering naloxone. There's lots of drugs that can lead to ultravenous status, but this is certainly one that's again, high risk of mortality and very treatable. So once you have your patient kind of stabilized, then you can sort of dig into the etiology. Again, acute ultramental status, this is a medical emergency. So if a patient aspirates on the floor, that's very different than if someone comes in and, has been altered for some time, subacute or even chronic. And then the other thing is recurrence. Is this a patient who you're seeing who's come in multiple times because they took too much or too little insulin, or is it someone who's come in with seizures before, right? So these are very important things to think about when trying to better pin down the etiology of the altered mental status. And then also baseline. What is the patient's baseline? And this can sometimes be the hardest thing to discern, especially in patients who are altered. This is something in neurology we struggle with a lot. You're trying to evaluate the organ that is dysfunctional. And so it can be hard, especially if they don't have someone with them, but it is very critical. So for example, here's a case: if you have a patient who comes in having a witness fall with head strike, and the scenario is incredibly different depending on if they live alone and were on their way to work, versus if they have Alzheimer's dementia and are dependent for all of their ADLs, right? And so if they're having, for example, amnesia, which you can see in patients who have, pretty bad concussions, but nonetheless, it really changes kind of your calculus when you're thinking about it. It's really important to determine their baseline if you can. And then you want to also obviously do your normal history. So do they have other systemic issues? If they have kidney disease, if they have cirrhosis, those are critical. And then looking for anything like signs of an infection, sleep changes, emotional changes, and so on. And then I always try to emphasize the importance of a medication review, because again, we're looking for the things that are reversible. And certainly there's so much iatrogenesis, especially in our elderly patients who, are on multiple medications, and especially if there's any kind of cognitive deficit, they can be hard to manage. So just noting if there's any new meds, if there are any interactions, if the patient's taking their meds wrong, if they're taking any supplements, and so on. Or if they had a change in, their renal function or their liver function, and now the meds aren't being metabolized properly. And then, of course, you want to do a physical exam. And so the general exam is critical in looking for any signs of, organ dysfunction, looking for anything to suggest drug use or infection. And then the neurological exam, you want to really look and see if there's any signs of focalities, as we call it. So if you're looking to see, like in our patient, is there asterixis, is there Parkinsonism, is there ataxia? And those can kind of give you hints as to the etiology as well. And so then in all patients, you're going to do some kind of workup. Again, we're sort of assuming that we've stabilized the patients who were kind of critical already. And these are patients who we have a little bit more time to think about. We want to rule out infection, especially in elderly patients, as you all probably well know. A UTI or an pneumonia can precipitate pretty severe delirium in elderly patients. So critical to look for those. COVID, of course. And you want to do some basic studies, AKG. And I always say, I just wanted to remind everyone that especially in our hospitalized patients, thinking about a bladder scan, because urinary retention can be a big cause of altered mental status in elderly, especially patients with dementia as well. And then from here, based on what you found in all of those studies, you can start to think about additional imaging. So, for example, if you found some focality on exam, right? If you saw that the patient seemed to be moving one side more than the other, depending on how acute you think it is, typically we start with the CT of the head, especially if you have any concern for blood, or if you think that it might be a stroke and they're in the window, although sometimes we can actually now get rapid MRIs as well, and those are certainly preferable in general. And then depending on what you find on the CT head, typically we progress then to an MRI, often with and without contrast, depending on the indication. If you have a patient who's having recurrent episodes and there's some suspicion for seizures, certainly an EEG, And I won't go into, I mean, we can get either routine or we can get prolonged being certainly more sensitive, but not always necessary. And that's where neurology can be helpful in making that determination. And then certainly LP is another consideration depending on the concern. If there's any question about infection, then you're going to get that right away. But otherwise, if there's concerns for, a neoplastic process or an autoimmune process, then that might be something that you would get a little bit later so that you can send off your cytology to the lab before 4 p.m. So it's processed on the day of and things like that. And then the other things that we, are important to kind of keep in the back of your mind is, thinking about psychiatric illness, and thinking about other kinds of even more specialized imaging like full body scans. And then based on all of that, you can think about your additional labs. HIV is something you might want to send on the earlier side, depending on, what you're seeing in the patient. Certainly thinking about other kinds of cultures or extended tox screens. Saw a patient recently who had come in covered in like pink liquid. It was a suicide attempt, and she was had all sorts of signs of anticholinergic toxicity, and turns out she had a Benadryl overdose. She was seizing. So that was, interesting physical exam findings that really clued us into that. And actually, poison control didn't even think that we needed to send anything because they were so confident that that's what it was. She did well. Medication levels can be important. Again, getting that med list and really knowing what they're on is very, very helpful. Thinking about thiamine and lots of other possibilities, again, depending on what you find in the early stages. So let's do a case. So this is Mr. P, 78-year-old man. He's chronic kidney disease. He has a long-standing seizure disorder. He was on phenytoin. Who was brought into the hospital by a neighbor after he had sort of 1 week of worsening confusion. And then on the day of presentation was found disheveled and mumbling kind of incoherently at home. At baseline, fully independent, lived alone. So obviously we don't have a ton of information, but I'm curious, does anyone have any thoughts, even just right off the bat, based on the information that you did have here? Yep, so uremia, totally. Very, very plausible. Any other thoughts? Yeah, infection, definitely. Seizures, yep, or meds, exactly. Yeah, exactly, great. So just by knowing anything about this patient, he could have missed his meds, or he could have taken too much of his meds, or some combination in therein. So excellent, great. So on exam, he was able to state his name, but he was unable to provide any history. He was sort of picking at his bag sheets. His cognitive exam was notable for disorientation to time and place, inability to follow complex commands, which might be, for example, can you point to the ceiling after you point to the floor? Couldn't do that. He was inattentive. He couldn't state the month of the year backwards. And he also had horizontal nystagmus, mild dysarthria, and he was ataxic. I'm seeing more things on the chat. Yeah, could be Wernicke. The nursing staff noted that he seemed to have moments of relative clarity and then some moments of confusion and increased somnolence. So I think I've heard some ideas of studies, but just to be really, so we talked about, I heard a phenytoin level, I saw that. I saw, well, if it's uremia, we can check his renal function. Anything else, any specific infectious studies you'd wanna? Yeah, a UA, let's get an BMP and a CBC, great. Tox, yeah. Chest X-ray, CT head, BBG. Awesome. We didn't even do all these things. Thiamine, great. Does anyone want an EEG yet? Bladder scan. Great. Okay. Great. So let me show you. So exactly. So So in terms of the progression, we've definitely got a bunch of labs on this patient, and then sort of progressed and ended up with a lot of information. So his head CT, so he had a seizure disorder, and that was due to a prior fall with head strike. And so he had some right frontal encephalomalacia that was old and known, so nothing new. I should have ordered this differently, but his UA was positive. He was hypernatremic, and he had an elevated creatinine from his baseline. He had a slight leukocytosis on his CBC. And then his free phenytoin level, which I'll tell you honestly, actually takes a really long time to come back. But if you get a phenytoin level and albumin, his level was definitely elevated, and his EEG did not show any epileptiform discharges. So that's what we did so far. And initially, he actually started to improve with treatment of his urinary tract infection and his dehydration with the hypernatremia, and we held his phenytoin and the level normalized. So again, just thinking about the altered mental status sort of pathway. So we ruled out kind of the other things that we're really worried about. We said, he had no seizures on his EEG, and we got a prolonged study. He had no new structural lesions on his CAT scan, although, if we had a higher suspicion, we could have done an MRI. And then we had a sort of a lower suspicion for a CNS infection. So we didn't pursue an LP yet, although that's something we had to sort of have in the back of our minds always. The patient definitely was delirious, right? We saw that he was acutely altered. He had this fluctuating course and a decreased level of consciousness. And so ultimately, the etiology of his altered mental status, and in this case, actually delirium, we thought he had phenytoin toxicity, a UTI, and hypernatremia. And so you're right, we could do like the bladder scan and see why all this happened, but for the purposes of this talk, we'll end there. And he actually got better as we addressed all these factors, which is the other really important piece of this, right? I mean, it was still possible that even if we found all of these things, there was something else that was, kicking off the renal dysfunction, and with that, the phenytoin and so on. But because he improved, we felt pretty confident that this was what was going on. So we're actually going to come back to Mr. P in a couple of minutes. But this is a nice segue into delirium and encephalopathy. So I think there's actually a lot of debate about what these different terms specifically mean. Delirium has a pretty specific definition. Again, that's an acute change in mental status that's characterized by this inattention, fluctuating course, and then either disorganized thinking or a change in your level of arousal. Encephalopathy is a little bit of a broader term and can be more, I'm going to answer that question in 1 second, can be used actually interchangeably with altered mental status, but I like to think about it in terms of, this is a patient who had encephalopathy or delirium, and then the specific etiologies for it. But basically it implies a diffuse process causing a change in the level of arousal. So the question is, what does a high phenytoin level cause? So that actually is why he had the nystagmus and the ataxia. So those are side effects of the phenytoin itself. The phenytoin is his anti-seizure medicine. So we didn't have any additional seizures from it. It was really these other side effects, and it can, lead to confusion as well. It's a bitter, yeah, of course, it's a bit of a dirtier drug, and the people that still are on it in their, 70s are typically people who have been on it for a really long time. Usually we don't keep people on it for that long anymore. So I just wanted to, again, talk a little bit about delirium. So I think about delirium the way maybe you guys think about acute kidney failure. I think of delirium as really like an acute brain failure because it is really this like diffuse process that is quite destructive. So it's incredibly common. Probably all of you know this and have seen it over and over and over again, but estimates of the prevalence range from about 10 to 30%, depending on sort of a general medical service. It can be up to 80% in ICU patients. And it's certainly higher in elderly patients or those with dementia. And in stroke patients, in my personal studies that I've done, it's been in the 30 to 40 range. So it's very, very common. And it's really bad. So, I mean, that's sort of like an obvious thing to say, but it's bad for patients. It's really bad for care teams, right? It's bad for hospitals and it's bad for healthcare systems. So all of this has been shown in separate studies. Delirium, increased rates of falls, people are more likely to have longer length of stay. They're more likely to, be institutionalized, more likely to go to a nursing facility than home. They have higher readmission rates, more sitter use. Then there's over time, worse functional decline and cognitive decline. And this is, a debated areas to, was it that someone had underlying, cognitive decline that was leading to the delirium in the first place or precipitating the delirium in the first place? Or is it its own process? But regardless, there's a lot of factors within the hospital. People with delirium more likely to aspirate, maybe less likely to get necessary studies. So there's a lot of different ways and end up with restraints or getting, Haldol and things like that. So there are a lot of different ways that you can imagine that there would be higher mortality and ultimately worse outcomes long-term. And then it's like very, very costly for the healthcare system. So, the hospital costs in the US are about 11 billion a year, but if you look at the post-hospital costs, you're talking about like 153 billion per year. And this is estimates from a couple of years ago. So really quite a terrible syndrome that we all see so often. And does anyone have a sense, this is where I had the polls, but I can't actually use polls here. So what percent of delirium is thought to be preventable? Any guesses? I have two guesses for 60, one for 40, 60, 40. Okay, yeah, I think those are pretty good. 40 and 60 is where we're sort of landing. And that's exactly right. So 40%, it depends on the patient population, but sort of more generally, and especially in the general medical population, 40% of delirium is thought to be preventable. And interestingly, like 2/3 of delirium is actually thought to be unrecognized. So these are from studies by Sharon and Yue.
I'm still not sure about that.
Oh, sorry, that's my watch that thinks I'm talking to it. Okay. And then when, does anyone know which of the following have been shown to be effective in reducing rates of delirium? Any thoughts from this list? E, C, C, C. Okay, so a couple votes for E, a bunch of votes for C. Okay, great. So yes, so C is the answer. Multi-component behavioral interventions are the only thing that have ever been shown to reduce the rates of delirium. There have been no medications that have been shown to be effective in reducing rates of delirium. And there have been many studies looking at this. So I think that's an important thing to keep in mind. So basically delirium is really common, it's really bad for everyone, and it's preventable. And I should say, in terms of the care teams, I think we probably have all also experienced this, that it's actually, and I actually didn't even mention families, but delirium is also really terrible for families. But in terms of the care team, I'm sure we've all experienced patients who become very frightened and confused and can sometimes in that case even, harm their caregivers unintentionally. So it is really can be very dangerous for everyone. So when thinking about delirium, I think we went through this with Mr. P's case, but I think the first thing is you want to really rule out anything else like a stroke, rule out a CNS infection or other systemic infection, seizures and so on. And then you want to say, pin it down, like this is delirium because you actually saw all of the cardinal features. And then you want to figure out the etiology, because in addition to the multi-component interventions, you want to really be trying to reverse the underlying etiologies. And then you want to go ahead and do the rest of your workup. It's not a diagnosis of exclusion. And I wouldn't say it's not an organic thing either, right? I mean, delirium, we don't understand it super well, although there's like, again, lots and lots of research into it. But, I think the first thing is making sure it's not something else, because, a stroke is something that you want to diagnose quickly, right? I mean, seizures are something that you want to diagnose and treat quickly. Kidney failure is something you want to, or med toxicity. So they have very different treatments. And then if you do think it's, delirium, you really, again, do need to truly diagnose it. It's not a diagnosis of exclusion. Like our patient, Mr. P, did have delirium. He met criteria for delirium, but the delirium was due to phenytoin toxicity, to uremia, right? And probably dehydration. Does that make sense? It's tricky. Like you're kind of doing all these things at the same time, but this is the way I think I like to think about it, as in this order, because I think it stops me from missing things. Does that answer your question? Okay. Yeah. So Mr. P, so I said he got a little bit better, got better when he did all of those interventions, but a few days into his admission, he became increasingly confused. He thought that his care team was trying to harm him and he was trying to escape. So security was called and he got 5 milligrams of intramuscular Haldol. And so when his children arrived the next morning, they found him in 4-point soft restraints, barely arousable. So you can imagine they were very distressed. And so, I think it's just, again, important for us to remember that it's extremely frightening experience for patients. There was actually a physician 20 years ago, probably, who wrote about his experience of delirium. He recovered very well and wrote very beautifully and eloquently about what he recalled being in the hospital. And he remembered literally feeling like he was being burned at the stake, that people were, trying to like peel his skin off, like horrible things. And he fully, he was hallucinating and seeing his care team doing these things in his mind. And so obviously that's terrifying. And that is very organic, right? He was there, he was septic and thus very, very ill. But I think it's also important to remember that pharmacologic interventions simply convert the hyperactive delirium typically into hypoactive delirium. So it's not actually reducing the duration of delirium. It's not treating the patient. It should only be used in the event that the patient is actually imminently harming or risk of harming self or others, or really interfering with their necessary care. But it also increases often the prolongs the hospitalization and increases the risk of death. As you all likely know, there's a black box warning for these medications, especially in elderly patients, for QTc prolongation, and there's higher, a study a couple of years ago showed that there's higher risk of aspiration. So ideally, we're preventing patients from getting here. And usually it's those that are kind of moderate risk that we can really make a difference. So that's that 40%. So in terms of prevention, this is a study from 1999 that some of you may know of. This is Sharon Inouye, who did this study at Yale and now is at BI, but BI in Boston. But she's a geriatrician and has studied delirium extensively. And she was the first to show that this multi-component intervention could reduce rates of delirium. So the intervention was along these 6 domains. So thinking about reorientation, sleep-wake disturbances, early mobilization, addressing visual impairment, so literally like glasses, having the patient's glasses at the bedside, and visual aids, and as well as hearing aids when possible, and also addressing dehydration. She was able to show a reduction in delirium incidence, and this has now been replicated all over the world hundreds of times. And so this used to be, it's called the Hospital Elder Life Program, used to be its own thing, and it was recently absorbed into the American Geriatric Society. So, going into the room and like opening the shades may make a big difference for patients. And certainly as much as we can try to implement these sort of simple, but, non-pharmacologic interventions, we're probably doing our patients a great service. So how much time? You know what? I think I'm actually going to skip this case and do a different one. So really quickly, we basically have already talked about this, but I'll just show, this is sort of the algorithm that I follow. So again, searching for the underlying etiology and thinking of management, really looking carefully at those medications, trying to retime medications. I don't know if you've ever had the experience of like patients who are getting furosemide at like 8 p.m. and then they're just like up all night peeing, right? Or patients who, their antibiotics are being administered at 2 a.m. when they really don't need to be. Those kinds of things, again, can make a big difference, especially for elderly patients or, people who are moderate or high risk for delirium. Trying to reduce opioids when possible, but still being, cognizant of pain, which is also in a deliriogenic. And then of course, thinking of withdrawal, from alcohol or opiates and those kinds of things. And then we have our multi-component interventions, which we talked about. And then only in the, the most serious circumstances when we really think a patient is at risk for harming self or others, or when we want to use typically the antipsychotic medications, Haldol, sometimes the atypical antipsychotics like Seroquel, although none of them has really been shown to be better than any other. And then one thing, in the ICUs, using dexmedetomidine is preferable to propofol or midazolam. And when you're doing these, just really being careful, always having an end time for when you're going to give them, not doing these standing. A lot of patients end up going home on antipsychotics when they're started in the hospital. So just being really thoughtful if you're going to, Presidex is what I couldn't remember the word for some reason. Okay, so this is last case. So this is Miss L. It's a 56-year-old woman who's having several weeks of fluctuating confusion, irritability, and difficulty sleeping. And she was sent to the emergency department by her PCP after her laboratory showed hyponatremia. And she was admitted to medicine where her sodium was corrected. But despite correction of her sodium, she seemed to worsen. And on day 3, she was noted by her nurse to be having occasional, sudden, brief flexion movements of her arms. Her exam was, or one arm, her exam was notable for difficulty with memory encoding, short-term memory recall, as well as mild inattention, and she had a little bit of myoclonus. What does everyone want to do now? And then I'll show you her movements, actually, okay. Yep, let's do a CT head and let's do an EEG. Good, anything else? BMP, yeah. Oops. Okay, hold on, let me just try to share this video with you. I tried to embed it, but it wouldn't let me. Okay, one second. Otherwise, I'm just going to demonstrate it myself, which is going to be not ideal. Okay, so I'm going to try to put up. I also want to fast forward so you don't see what they are. Not that it's so clear. Can everyone see this? Can you see it? I know I don't have it even like full screen. Yes? hopefully. Okay. I think I missed the first one, but they're very subtle. So that was one. Yeah, so that was one. Let's see if I can show a different one. Right. Oh, I see. So she was pressing the button because she knew she had it. Okay. So trying to go back, but not so far that you see. There you go. Here. There you go. So that was, everyone saw that? Okay. So that is what we're dealing with in our patient. Okay, so we're gonna get a CT head and an EEG. So actually, I should say, in this case, because she had been there for kind of a while, we could do a CT head, but in this case, we went straight for MRI brain and with and without contrast, and that was because we had a specific suspicion. Definitely, we got an EEG and we did a lot of basic studies, which were otherwise unrevealing, except for that hyponatremia. So we got an EEG and it was actually normal, but notably we hadn't been able to actually capture the episode of arm flexion. But I will say that even when capturing, the EEG can be normal in this particular syndrome that I'll tell you about in a second. And what was notable was when we got her MRI, we saw T2 hyperintensity and some edema in the right mesial temporal lobe. So you can see it right there. See how it's a little bit asymmetric? The mesial temporal lobes are always a little bit brighter, but in this case, this is certainly brighter than this, and it's swollen. So there's less space right in here than you would expect on this side than on this side. And then there was also just a little bit of enhancement suggesting some blood-brain barrier breakdown. And then we did end up doing a lumbar puncture, which showed a mild lymphocytic pleocytosis. Any thoughts about the one other thing that we should send from the CSF? And this is like a totally tricky one, but anything that you would want to send now that you're seeing this? Yeah, HSV is a good thought. Usually HSV is it takes up a bigger area of the temporal lobe, it's a little more destructive, and it's not as sort of subacute, but it's certainly reasonable, and you definitely want to rule it out. You would probably want to send it and make sure it's negative. It was in this case. And then autoantibodies, great. And then there's a question. So we did send autoantibodies, and I'll show you what came up there. So how do we decide between with and without contrast? So typically, if you're just looking for, not just, but if you're looking for like a stroke and you have a high suspicion, for that, you don't need contrast. But if you're thinking about anything inflammatory, infectious, or neoplastic, you want contrast, basically. Sometimes we don't have any choice and we don't get contrast because we can't. But yeah, that's typically how we decide based on what we're thinking about. Welcome. Okay, so we did send autoantibodies, and in this case, because of the presentation, which is actually very classic for something called Lgi1 Limbic Encephalitis, we sent off the panel, but actually treated her empirically with steroids. So Lgi1 encephalitis is characterized by mild hyponatremia and these faciobrachial dystonic seizures, as well as often some sort of more subtle cognitive changes or behavioral changes. It's usually not a perineoplastic process. So typically it's just an autoantibody process, and we start with steroids, and people can respond pretty well to steroids. And that's what happened in this case. She actually improved even before we got that the positive Lgi1 antibody back. And as I said, the EEG can be normal in some cases, although it doesn't have to be if you were able to capture the episodes. And that's all I have. I'm finishing with 1 minute to go. Does anyone have any questions, comments, concerns, thoughts? Okay.
Much, Dr. Ryan. And I guess, if anyone has any questions, we still have a couple minutes. You can still post them on the chat. But that was a fantastic presentation. Thank you so much.
Thank you. Thank you so much for participating. It's much more fun for me, and I hope more interesting for you as well.
It was, and even without the polls, I think it worked out very well.
Yeah, exactly. I know. I was like, oh darn, but yeah, it did work. I think it
For our
worked out
next
great.
invitation, you'll send it over, and we'll deal with that.
Right.
side.
Next time I'll be, yes, that will be better. Awesome. Well,
So
you
much.
also can always find me on email if you have any questions going forward, and I'm sure I'll see you around the hospital or maybe even on our nurse or service. I think I've certainly met some of you. So awesome. Thank you so much.